I will very quickly, in a very short while, go through generating evidence to inform the response in Uganda. As Dr. Mark Daibu emphasized, we are trying to zero down on where the infections are to be able to have more targeted interventions and further bring down the new infections. And we have been doing this through various approaches. There have been modes of transmission studies that have tried to highlight the source of new infections. The last one done in 2015, which identified the high-risk groups. And right now there is an ongoing impact assessment that's going to generate further evidence. And then we've also had several other opportunities to generate data from the demographic and health surveys, as well as cohorts and clinical trials in some of the areas. And I will highlight some of the evidence from some of these. There's also the modeling studies that Ministry of Health has been doing with partners. And then the Ministry of Health has been working closely with our School of Public Health at Makerere University on various studies as well. Just some of the evidence to add on to what Dr. Mark Daibu was raising. For Uganda, right from the modes of transmission studies, there are several populations where we see very high risk and very high prevalence. The average national prevalence of 7.3%, but you can see some of these populations, especially the fishing communities, the sex workers, and then we have the truckers as well as uniformed personnel and men who have sex with men having a much higher prevalence. But also just to highlight that we still do have a bit of gaps in evidence, especially in terms of mapping of these groups across the entire country, because some of the studies that have generated these have been largely around Kampala, like for sex workers and for men who have sex with men. So there's still need for us to do further mapping across the countries. And then this is showing fishing communities. There are many studies that have been done in Uganda in fishing communities. And you can see several of them, especially around the Choga regions, rather the Lake Victoria regions, show very high prevalence, ranging from 20 to about 40% compared to the national average of 7.3 in 2012. So their fishing communities are really a major issue. And then we also did another study around fishing communities in the Choga region, where we found that the prevalence was lower than that around Lake Victoria, but still significantly high on average, about 14%. And you can see these areas with fairly high prevalence, above 20%, 10 to 20%. So these are some of the areas that we also picked. And again, this is related to the data that Dr. Mark Daibu was showing. So we have quite a number of these areas that need very focused interventions. And in this, we also looked at young population. This is an analysis we did about 1 or 2 months ago. And looking at data from the Rakai Health Sciences program, we pulled out 792 young people between 15 to 24 years. And we found, again, surprisingly, a very high prevalence. We thought it should have been a little lower than this. And this is the village where HIV was first identified many years ago. So we thought it should have been better, but we still have, on average, close to 20% overall. And among the girls, the prevalence was 26% compared to 12% among the boys. And then we also noted that the prevalence was actually reducing as you move. This is the landing site, and as we move away from the landing site, you actually begin to see the reductions in HIV prevalence. So again, this highlights the populations as well as some of the sites that we need to be focusing on in our interventions. We also noted from our Choga study specifically that fishing communities were very vulnerable. For example, in Choga, other than the 14% HIV prevalence, we had very high syphilis as well, and schistosomiasis was about 48%. And then we are planning to look at also hepatitis in the same area, because we think that this could also be quite high. So just to highlight that these communities have a lot of challenges with other infectious diseases. They also have issues with poor access to health services generally, and we need more comprehensive interventions to be able to deal with the issues around these communities, which are also very mobile, and because of that present a number of challenges in terms of delivery delivering services. We've also done several studies with the Ministry of Health. One of them was focusing on access to services among MSM and sex workers. And then we've done a comprehensive condom review, a primary prevention review for Uganda. And then we've done a PMTCT, retention and adherence study. And we have recently started working on this jointly with Kyoto University, looking at prevention and other programs for young people. And I hope that this is an area we can further develop, given the high HIV prevalence figures that I've shared with you. I hope we can discuss it further and see what more we can do in this area. So we have been using this data with the Ministry of Health, and some of these studies actually informed the last application we did to the Global Fund in 2014, and we've also shared it with other partners in country, including PEPFAR and other agencies to be able to better target the programming. In conclusion, we would like to say that Uganda is implementing a comprehensive and evidence-based HIV response, and we have done this through engagement of multiple stakeholders. And we are beginning to see some improvements in the indicators. Initially, we had a bit of stagnation, but right now we are beginning to clearly see dramatic declines. But it's also very clear that we need to further consolidate and develop more innovative approaches around targeting specific populations, young people, key populations, and other priority populations, such as the fishing communities. Thank you very much.